Time for some clinical peanuts.
Yeah, you can go ahead, Dipti.
Ha. Sir, my camera is not opening.
It's okay. Hmm.
Uh, Good evening, everyone. I'm Dr. Dipti Patil, DNB JR3 at Anuradha Hospital, Sangli. Uh, so I'm starting with my case presentation.
Yeah, so go ahead.
Uh, 82-year-old lady, a resident of Sangli, Mrs. Kamal Patil, came to our institute with chief complaint of right eye, sudden painless loss of vision since 5 days.
Okay.
Uh, then history of present illness, sudden painless loss of vision in the right eye, which is painless in nature. Uh, there is a history of any um, use of thick glasses, no history of distorted vision. But she complains of she feels there is a curtain is a black falling curtain in front of eyes. There is no history of floaters or shower of black floaters in front of eyes or flashes in front of eyes. No history of photopsia. Then there is no history of weakness in
So,
either limbs or
Dr.
arms.
Dipti, so what do you mean by photopsia?
Photopsia is the patient feels there is a flashes of light even after closing eyes, even after closing their eyes.
Yeah. So now you are presenting a case, right? For exam.
Yes, sir.
So it is always in the language of the patient.
Oh, sorry, sir.
Yes, so how you have
Yes, yes,
beautifully
sir.
described that there is no shower and there is no patient is not seeing a curtain-like thing. So you should not say photopsia.
Yes, sir. Yes, sir. Sorry, sir.
No, 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 sorry. Just because we are presenting a case for exam point of view. Okay?
Yes, sir.
This
Yes,
is
sir.
not for just to know a theory part. Very good.
Yes.
So tell me more causes for photopsia.
Photo. It is due to the retinal traction, maybe in the uh, incomplete PVD there is a traction, or in diabetic retinopathy if there is a traction on the retina
So
by
what is the difference between a traction in a diabetic retinopathy and a traction in incomplete PVD? Or a difference between a traction in a diabetic retinopathy and a traction in a retinal detachment?
in retinal detachment it is the uh, uh, be- between the neurosensory retina is the detached, and in PVD there is a vitreous is detached. So
No.
sorry, sir.
No, no, that's okay. So one thing is, yeah, you have to make yourself clear. Any retinal detachment when we are talking about, okay,
Yes,
by default it is between a neurosensory layer and a
and the RP,
okay,
retinal pigmentation
unless
film. Yes, sir.
specified, unless we are saying it is a retinoschisis or otherwise it is if we are saying it is exudative retinal detachment, still it is in the layer between neurosensory and RP.
Yes, sir.
Okay. So
Yes,
now
sir.
what I am asking is what is the difference between a traction and tractional retinal detachment and a regmatogenous retinal detachment? Anyone else would like to take also can use the mic and answer. So Dr. Dipti, in short, I am asking you what is difference between a tractional retinal detachment and a regmatogenous retinal detachment in terms of traction.
In tractional retinal detachment, there will be separation between the NSL and the RPE. But in rhigmatogenous, it will be because of the separation of the vitreous from the ILM, which will be accompanied by a hole and a liquefied vitreous or vitreous cineresis, which will ultimately eventually lead to RD.
Yes, so that is how it will progress. But why there is traction? What is the difference between the traction between the two? So if you
In
have
the
read
levels at which
Lansky,
it is induced.
pardon me?
In the levels at which it is induced.
No. So see, vitreous is always attached. Okay, in both the case, vitreous is causing traction, right? But this is
Yes,
a
yes, sir.
static traction.
Yes, and yes,
Fractional
and in
retinal detachment, it is a static traction. And in case of a rhegmatogenous retinal detachment, it is a dynamic vitreous traction. Okay, so
okay,
there
sir.
is a
Yes, sir.
constant pull, and that is why it tears off the retina. And once it tears off, there is no pull on the retina. That is why sometimes you see the operculums, operculated
Yes,
retinal tear. There is no traction now. And if the traction is still present, it is present on the flap of the tear. Okay. So
yes,
if you
sir.
read Kansky, it will mention there are two types of traction.
Yes, sir. Dynamic and static traction they have mentioned.
Yes. So that is very important because this traction is static.
Hmm.
Okay. That's why it will
Yes,
not change with movement of the eye and everything. Okay. But a dynamic retinal traction changes with movement of the eye. Okay, so sometimes you will have people advising people with a horseshoe tear, or even if they are not lasering, then they'll say don't do strenuous work, don't do exercise, because if you do that and there is a PVD which is induced, then there will be a bigger tear happening, and then as Dr. Aishwarya said, there will be vitreous which will seep through and it will detach the retina further. Okay, so now
yes, sir.
what are the causes of photopsia? Tell me. Patient presents with photopsia. So what you are thinking? What can it be? Anyone? So basically, what are the
Rhegmatogenous RD,
very nice?
DVD.
Yes.
But any kind of retinal detachment there may be.
No, not really. You won't have an exudative retinal detachment.
It's not in the exudative. It is in tractional and rhegmatogenous retinal
Fractional also
detachment.
generally you will not have this. Okay. So other thing,
Mhm.
can any inflammatory disease cause photopsia?
Intermediate uveitis.
Not intermediate uveitis. Anything to do with it has to do with something with retina, right? To cause flashes we are talking about, not floaters.
Posterior uveitis
Yes,
or
which type of posterior uveitis?
chorioretinitis.
Sure.
No, you have to tell me, does toxoplasma cause flashes? So it is classically seen with azure. Okay. So you have to keep that in mind. If a patient comes with complaints of flashes and you are seeing inflammation, then you should think that there could be a case of azure. Okay. Now, azure is
Yes,
very
sir.
difficult to diagnose. Okay. How will you diagnose azure?
Mhm.
ठीक है. We'll go forward from there.
Sir, will ARN cause photopsia?
No.
Thank you, sir.
Okay. ERN will cause metamorphopsia. Okay. Next, go on, Dr. Dipti.
In past history, patient is known case of hypertensive since 30 years and she is on treatment. She is on
Okay. So again,
antiplatelets.
patient is not a known case of hypertensive. Patient is hypertensive or patient is a
Or
known case of hypertension. Okay. Some
yes, sir.
examiners are very particular and this. You are absolutely right in what you are saying, but they'll still be. And in your exam, you don't want any this. You don't want a speed
Yes,
breaker. You want to cruise through that. Just I didn't have any
yes,
signal. You want it like that.
yes.
Okay. Because anything, even small thing, then they'll ask, is it right? What you are saying? then you are again confused. So get into the habit of yeah, yeah. So there
Uh,
is a known case of hypertension and
uh, she since 30 years and she is on treatment for the same.
okay.
And she is on antiplatelets since last 10 years.
So there's any history of photopsia in the family?
No, sir, there is a no such same history in the family.
Any systemic disease can cause photopsia-like phenomena?
Mm.
Some migraine.
Absolutely.
Ocular migraine. Yes.
Yeah. Pardon me? Yeah. So migraine is very important. Yeah, not ocular migraine, just a migraine. Okay. A simple migraine is classical, has this scintillating, what is that other word associated with it? So they see these light sort of things.
Mm.
Okay.
Halos. Yeah,
Yes.
halos.
Auras.
Yeah. Aura is the very important word for exam. You should not. Yeah. So go ahead, doctor.
There is a no significant any drug history for
Okay.
long-term duration.
Very nice.
There is a no any past surgical history. She is underwent cataract surgery in the both eyes in last 5 years back.
Okay.
And there is no any history of retinal surgery and retinal laser. So, do we need to specifically mention that it is not done any retinal surgery or
No, there's no need to mention because there are so many surgeries which are not done, right?
okay,
So,
yes, sir.
yeah.
Personal history. Uh, there is a no history of use of tobacco. Then family history. Families no similar complaints in the family. Um,
Any drug
then
history you
general.
would like to ask?
Sir, for
Your case?
uh, uh, sir, ethambutol for tuberculosis.
Your patient is,
No, no, she is not on any drug for the for
so then
long
why
term duration.
ethambutol this? What does ethambutol cause?
Uh,
Toxic optic neuropathy.
toxic optic neuropathy.
Very nice. So how will
Yes.
the patient present with?
There is a pain on ocular movement, color vision defective. Sorry, that is
There
optic
is no
neuritis.
neuritis, right? There is no
Sorry,
info.
sorry, sir. Uh,
No, don't apologize, please.
There will be scotomas.
No. So if you say scotoma, then whether there will be a positive scotoma or a negative scotoma. And what is a positive scotoma and what is a negative scotoma? In which
Uh,
diseases there are positive scotoma and which diseases there is negative scotoma?
Positive scotomas are the scotomas in which the
AR,
patient will give you the history key they cannot see in a particular quadrant, while negative
Right.
is the one in which it will keep
black.
contracting on its own
Right.
without
So
any
in which
symptom.
disease we see a positive scotoma? Commonly patients like
ARMD.
Yeah.
not ARMD, but a CNVM, yes,
Mm.
and
Macular hemorrhage, a big
yes,
macular.
yes, anything which is above macula,
Mm.
okay, even a CSR can give rise to a positive scotoma.
Mm.
Okay, patient will say, oh, बीच में मेरे को ग्रे ग्रे दिखता है. Okay, so
Yes,
these
sir.
patients, ethambutol patient, will not present with the scotoma. Okay, they will present with negative scotoma. Okay, they will just have
Okay.
diminution of vision. Okay, there is no this, but color vision is very important. Okay, there on examination you will have color vision defective, and it may be a gradual loss of vision, or it can sometimes be sudden also because they generally not are opthal patients, so they don't realize
Mm.
that their vision has come down. Okay,
Okay.
so what test you'll do for ethambutol toxicity?
Perimetry 30
Uh,
2.
Very nice.
mm.
What you will see in perimetry?
Quad or
Which
hemianopia,
quadrant?
depending on which are
Oh,
the
so if
fibers.
you see
Hemian.
quadrant anopia and hemianopia, if you see, you will directly jump for an MRI. Okay. So you will see there is no specific signs for ethambutyl toxicity on perimetry, but you may see a generalized reduction or you may see some scotomas. Okay, but you can see sometimes enlarged blind spot, but there won't be a quadrantanopia or a hemianopia. If you see any anopia, you have to do MRI because these patients are coming with how will be the fundus picture.
There will be optic disc pallor.
No, there won't be any pallor. There will be, they have just developed the neuropathy. So these fundus will be absolutely normal. Okay, so if a patient with normal fundus comes with hemianopia, you are going to think of a compressive lesion. Okay, so they generally don't have hemianopia in this. And yes, sometimes the disc can be involved, it can be hyperemic, or there can be mild disc edema. What are the other drugs which can cause a optic neuropathy from which are used in TB treatment?
Isoniazide.
Pardon me?
Isoniazide.
Okay, and
Mm.
what drugs are used in MDR TB?
Linezolid.
Yes. Okay, so linezolid is very important
Mhm.
because patients of multi-drug resistant TB will not be on ethambutol.
Mhm.
So when these patients come to you and you say there is no ethambutol, so it's not my job. There is no optic neuropathy. You are going to jump for MRI. It may give non-specific things. Okay, so in linezolid, especially sometimes you can see a hyperemic disc. And so what is the treatment for ethambutol toxicity?
You
So
have
there
to
is
stop the drug.
Very
Yeah.
important. You have to stop the
Mm.
drug and you have to, for exam point of view, and even in your practice, you have to ask the patient to consult with the physician. Why?
Physician.
Because
Alternative
for
for the.
you can only see his eyes, but his life is more important.
Yes.
Okay. So this physician will take the decision whether he can stop that drug, whether there is any replacement available for it. What is the stage of TB? So you have to mention that this is probably the drug of causing the temporal toxicity. So you have to ask the patient to refer to the physician, go back to your treating doctor and ask them to stop this drug and go for a replacement. Okay.
Yes, sir.
Yes. So coming to our this,
Mhm.
which drug, any drug you would like to ask? Any history of using any drug? Any eye drops?
Pilocarpine.
Yes, very good. So pilocarpine can be associated with RD. Okay, so that would be a point in your negative history or in your drug history. Okay,
Okay.
patient doesn't give history of using any drops.
Yes.
Okay, so
Hmm.
now have you ever used pilocarpine, Dr. Dipti, on any patient,
Sir.
not yourself?
No. Uh, Sir, we just used intracameral, not as a eye drops.
Yes. So which patient will use this drug? If there's nobody, you have
Uh,
used in 2 years, so who will use? Can anybody?
Angle closure glaucoma.
and
Yes, angle closure, very rare.
so even in identifying uh, pathologies with the pupil,
Before
dilate
yeah,
pupil.
PL
But they'll just use it once, na?
hmm,
This is like
not for
talk about,
chronic use.
yeah, chronic use. So there is no use, right?
For laser peripheral. No, not chronic case.
Dr. Dipti, so there is no use, right? For chronic, we are not
Not
using
like
there, na?
it is a drug used for primary angle closure glaucoma, but
But
we are
where
not
we are
using,
using, where it is only old
not,
patients you will see ki they have come from medical college and somebody has treated them 30 years and they are still on that drug. Your
yes,
glaucoma consultant will never put them on pilocarpine,
yes,
right?
yes, sir.
So is this history relevant in today's time or not?
Yes, sir. So
Yes.
the diluted pilocarpine has been started as a treatment for presbyopia presently.
Yes, this is very important for exam point of view. Even if you don't use
Okay.
this, you have to remember ki nowadays people will be using pilocarpine for presbyopia treatment.
Presbyopic correction.
Okay, so now it has become relevant.
Okay, sir.
Okay, 2 years back, if the examiner would be talking about this, you would come out and say, "अरे पता नहीं क्या बोल रहा था, कौन सा दवाई चाहिए था, मेरे को नहीं मालूम." Okay, so pilocarpine is very important. Okay,
Yes, sir.
ठीक है, go ahead.
On general examination, patient is well built and nourished. Patient is cooperative and well oriented to time place person.
In
Sir,
general
for
examination, what you would like to look in a case of RD?
So in general
it is a
examination,
normal
patients with Marfan or Stickler syndrome, hyperelastic
Yes.
joints.
family,
Yes, so
um,
if you're seeing a
family
very
or
tall
withdrawal.
patient,
Yes,
okay, so that could be a giveaway that maybe they have some Marfanoid features and that could be the reason for a retinal detachment.
retinal damage.
Yes, go ahead.
Sir, for systemic examination, if it is normal, then we have to say it is normal, or we have to elaborate. If,
You have to say that S1, S2 and all those things.
on cardiovascular examination, S1, S2 is heard. Pulse is 74 beats per minute in the right radial artery, and BP is 130 by 80 millimeters of mercury in sitting position in the right brachial artery. Uh, in respiratory examination, air entry is equal on the both sides. For
So if
example,
you talk so much, they'll say, okay, okay, go ahead. Come to ocular exam. Yeah.
on ocular examination, uncorrected visual acuity in the right eye is hand movements close to face, and in the left eye it is 6 by 24. And with pinhole, it is not improving in the right eye, but it is in the left eye it is 6 by 9. And with
The
the
cause of
refractive correction of,
non-improvement of pinhole vision.
sorry, sir.
In which conditions the pinhole vision will not improve?
If macular pathologies are there, then will not improve.
Okay. In case of RD, will it improve or not improve?
If it is involving the macula, it will not improve.
Very nice. So if it is a macula on RD,
No, if it is not improving, it's suggestive of it is macula of RD.
very nice. Okay. ठीक है. Go ahead.
Uh, in intersegment examination, torchlight findings are confirmed on biomicroscopy, slit lamp biomicroscopy. In the right eye, lids are normal, conjunctiva is normal, sclera is normal, cornea is clear, antechamber depth is normal,
What are you looking
and
for conjunctiva in a case of RD? Patient has, you are saying that patient has retinal detachment.
yes, sir.
Okay.
No, no, patient did not say that.
No, no, I'm
Just,
saying you have a patient who has a retinal detachment. Can he present with red eye?
yeah, it can present if it is a exudative retinal detachment.
Yes, so that is very important. So if there is any signs of inflammation,
No, there are no signs of
okay,
inflammation.
go ahead.
Mm. Then iris is normal color and pattern.
Mm-hmm.
Pupil is a slightly sluggish reaction in
Okay.
the right eye, and in the lens, it is a posterior intracorpuscular lenses plus patient
अरे
is
तुम्हाला आवाज
pseudophakic.
दिला ना मोठा करून.
Yeah, go ahead.
In the left eye, lid is normal, conjunctiva is normal, sclera is normal, cornea is clear, interchamber depth is normal, iris is normal color and pattern, pupil is normally reacting to light, and lens is posterior intracorpuscular lens is there. Patient is pseudophakic, and on distant direct ophthalmoscopy, uh, glow is altered in the right eye. The left eye is a normal glow is present, and intraocular.
So, what is the significance of an IOL in case of retinal detachment?
During maneuvering, there is collagen cross-linking is
With IOL?
no
If
during
aphakic patients,
surgery during surgery of the
So vitreomacular traction can be increased during cataract surgeries, which might predispose a patient
So
to.
basically, you should not say vitreomacular traction. You should say a PVD can induce.
okay
Okay. And it can lead to an RD. Just simple
RD.
cataract surgery can also lead to an RD. But what about the IOL? So you have to say where is the IOL, whether it's in the back, it's in the sulcus. Okay.
Yes.
You can mention that. Whether the posterior capsule is intact.
Hmm. Um, it was intact.
Yes.
If it is a break, then there is a chances of
This you have to
say
mention in all your cases, not just in this case. You have to mention that there is
okay,
posterior capsular
absolutely.
intraocular lens in the back with intact posterior capsule.
Yes,
Because some patients can have even a yak capsulotomy.
yes,
Okay.
yeah.
So, and some patient can have a intraoperative rent.
Intraoperative and yes.
Okay. So again, a intraoperative rent will
Uh,
predispose to a
induce traction,
rhegmatogenous retinal
rhegmatogenous
detachment.
retinal detachment. Yes.
Okay. So what are the complications of posterior capsular rent?
There is extension of the rent, so due to this, we cannot place the lens in
So there can
sulcus
be
also due
intraoperative
to
complications and postoperative complications.
post-operative
Yes,
complications. Yes,
intraoperative, that inability to place lens, and we would have
place lens.
keep
Lens drop.
kick. Yes, then next.
Vitreous prolapse into the AC.
Yes.
Lens drop.
Shallowing of the AC, sudden shallowing of the AC.
Okay.
Lens drop can occur.
Yes.
Hmm.
Nucleus drop can be there. Again,
Hmm.
if there's vitreous in the AC, then where it will go next, Dr. Dipti?
Sorry, I didn't get you, sir.
There is vitreous in
Uh,
the anterior chamber, right? So
yes,
what was the vitreous earlier?
in the vitreous cavity in the posterior segment.
Yes. So now it has come into the anterior chamber.
Anterior, yes,
So आगे किधर जाएगा? Where will it go next?
it will try to come out from the wound incision site.
What is the name?
Oh,
Vitreous Wick syndrome.
Yes, that is what
stress
examiner
mix
is
syndrome.
looking for.
Yes.
So this should come spontaneous.
Oh, yes.
Third. Since first year we are 3 months we are talking only about complications. We are reading Stellards. So this
Hmm.
should be yes. Okay. He should
Yes,
not
sir.
be asking you. You should be telling.
Yes, sir.
Okay. So how to manage intraoperative complications? Forget aphakia. Next, there is vitreous and AC. What to do?
Sir, vitrectomy should be done first.
How you
First,
do?
no, sir.
First,
First, if there is a nucleus or
No,
any
no, there's just vitreous
nucleus
in the
lens.
AC. Rest everything is fine.
Okay.
Yeah. How do you manage vitreous in the AC? There's a PC rent. You have removed the nucleus. Now there is a rent, and the vitreous has come in the AC.
Stain with triamcinolone known
It's
as
time.
anterior vitrectomy.
Yes, so you have to mention you can do either a manual vitrectomy or you can use a vitreous cutter. Okay,
Yes.
and you stain with?
Triamcinolone acetinoid.
Yes, very good. Okay, ठीक है. Go ahead.
Intraocular pressure in the right eye is 17 and in the left eye it is 16.
Right.
And
So what is the
posterior,
significance of intraocular pressure in case of RD?
it is in case of RD there is a low intraocular pressure is noticed.
Yes. Can there be high intraocular pressure in case of
Yes,
retinogenous
there can
retinal
be a
detachment?
high there can be high intraocular pressure.
What are the reasons
It's
for that?
uh, it it is due to the pigments blocking the trabecular meshwork, the
So what's the syndrome? Schwartz.
Schwartz-Mitsu syndrome.
Okay. Next.
Mm. Mm. Um, Suprachoroidal effusion
Okay, if there is trauma,
trauma.
yes, suprachoroidal effusion, very right. Third, if it is a known case of glaucoma, is it
No, she is not.
No, if it is a known case of
No.
glaucoma, pressure will be on the higher side. Okay? ठीक है. Go ahead.
Mm, on posterior
And
segment
one more
exam,
thing is NVG.
NVG.
So can you have NVG with rhegmatogenous retinal detachment?
Mm,
Is there an association?
no. No, sir. Rhegmatogenous there wouldn't be.
So if you have a long-standing rhegmatogenous retinal detachment, because of inflammation, it can lead to a neovascular
Yeah.
glaucoma. Okay? Yeah, go ahead.
On posterior segment examination, in the right eye, medias are clear. Disc is normal size and shape.
What you
Neuroretinal
would
rim is
expect in
healthy.
case of rhegmatogenous retinal detachment in the media?
Tobacco dusting or Schaefer's sign.
Very nice.
Shepard's and tobacco dusting is
Yes. Okay. So we can see tobacco dusting Schaffer sign, which is a sign of
uh,
Acute or
where
very recent onset
reset
RP.
onset retinal detachment. So RP
so it is
pigments
not
are
a
seen.
sign of retinal detachment.
It's the
PVD.
release of RPE pigments
It
is
is
there.
not a sign of PVD. Yes, it is sign of release of pigment. So it is
RPE
a
It's
Sign
sign
a
of
that there will
sign
be
of
tear,
retinal tear.
retinal tear.
tear.
absolutely, absolutely. So don't use the word retinal detachment. You have to find the break, and if you cannot see anything, then you have to suspect that there may be an RD. It can progress. So if you are seeing, okay, so if you are seeing the tobacco dust sign, and patient comes with diminution of vision, so in your mind you're already thinking that there is an RD.
Okay.
Okay, but it is not a
Yes.
sign of RD. It can be associated with RD, but what it means is there is a break.
Yes.
Whether retina has detached or not, it can be there, it may not be there.
Mm.
Okay, and how do you see tobacco dust sign? On 20D, on direct ophthalmoscope, how do you see?
Around slit lamp examination.
Also
Yes, yes, you see on slit lamp examination. So where do you focus?
on the posterior capsule.
Yes,
Beyond the posterior capsule.
yes. So where the anterior vitreous is there.
And yes.
Okay, so you have to go beyond the posterior capsule. Okay, yes.
So one question.
No
So does
question,
it
only answers.
so no does it uh, like tell us about the chronicity, whether is it an acute tear or a chronic tear?
No, not really. Okay, so sometimes there can be hemorrhage also. Okay, because of PVD there is hemorrhage. So this is just means that there is a break in the. We cannot know whether it's a chronic or acute.
Okay.
Okay.
Thank you, sir.
Yes, Dr. Dipti, go ahead.
Cup disc ratio is a 0.4:1 in the right eye,
Mm-hmm.
and in the macula there is a elevated convex undulated grayish corrugated retina in the temporal quadrant extending up to the macula with the horseshoe shaped tear in superior temporal quadrant.
Okay.
Um, and foveal reflex absent in the right eye. Hello.
Yeah, go ahead. So this is on
And in the
direct ophthalmoscopy or how you are saying the retina?
first, I have seen in the, on the 90D, then retinal detachment is noticed. Then I done indirect ophthalmoscopy.
So did you tell?
Oh, no, sir.
So you have to tell me, right?
Yes,
So you have to tell me on slit lamp biomicroscopy.
microscopy.
You which lens did you use?
20 slit lamp biomicroscope 90D lens is used,
Okay,
and
not 90D lens is used. I have used 90D lens.
I
Somebody
have
can
used
use a
90.
78D also,
Mm,
right? Hmm.
yes, sir.
Okay.
Uh, And in the left eye, medias are clear, disc is normal size and shape, neuroretinal rim is healthy, and curved disc ratio is a zero point 0.4 CDR, and in blood vessels are dichotomously branched.
Hmm.
Sorry, sir, I forgot to mention in the right eye. It is dichotomously branched, and art artery venous ratio is 1:3.
Hmm.
In and in their left eye, medias are also normal. Sorry, macula is normal. Foveal reflex is present.
Okay. Take it. So what do you want to do in the left eye?
Left eye,
Why are you checking the left eye?
peri
Patient has problem in the right eye. You have seen there is a problem in the right eye. What do you want to check in the left eye?
in periphery, if there is any
So did you check the periphery?
retinal degenerations are there.
Did you check the periphery?
Yes, sir.
Okay. So how you will check the periphery?
By with the help of indirect ophthalmoscope and plus 20D lens, and with the indenter in the patient is in supine
So did you
position.
indent?
That I just able to indent superiorly, but not the
Who's
inferior.
asking you how, what you know, what you have to say, right?
Yes.
Anna? They are not going to ask you to demonstrate. Even if you
Okay.
they ask you to demonstrate, you just press it. Even if you cannot see,
Okay.
but you have to mention, right? On indentation. Hmm? Okay.
Yes,
So
sir.
where do you indent?
Uh, about 3 to 4 millimeter behind the limbus.
3 to 4 millimeter behind the limbus. And what is, have you given any injections ever? Seen anyone giving injection
Yes, sir.
in the vitreous cavity?
Yes, sir.
So where, how do you give?
It is given
What distance?
in 3 millimeter in aphakic eye from the limbus, 3.5 in the pseudophakic,
Why
and
are we
in
giving in that,
phakic it is
that?
because pars plana is there,
So
so
what you want to see? When you are indenting, what do you want to see?
we have to see the aura
And the
and
retina,
at
right?
retina at the end of the attachment at the aura.
Yes, and you have to go even posterior,
Yes,
right? So
yes.
why you will indent at 3 mm? Where there is pars plana, do you want to see the ciliary bodies?
So, sir, behind that we have to see the
And where
retina
you will
at
keep your indenter? You will keep it on the lid or on the sclera, on the conjunctiva, where you will keep?
On the
So
lid.
the folds of the eyelids.
Lids, we have to put it on the lid,
So
from the
you can
eyelid
you can
that
put it even
indent.
on the conjunctiva, you can put it on the lid. Okay. You can put it anywhere. Okay. Both are okay. Okay. The only thing is if you put it on the conjunctiva, the patient is a little more apprehensive and you have
Irritable.
to use topical anesthesia. Okay. And the other thing is about sterilization issue. You have to clean your indentar, which I don't know how is it about you, but I have never done that. So those things are there. Okay. So so you have a so what is your diagnosis?
So, on the basis of history and clinical examination, my probable diagnosis is the in the right eye there is a horseshoe-shaped tear in superior-temporal quadrant with the retinal detachment involving the macula, so suggestive of a rhegmatogenous retinal detachment in the right eye with the pseudophakia and grade 1 hypertensive retinopathy, and in the left eye grade 1 hypertensive retinopathy with pseudophakia.
Okay. So what are the signs of hypertensive retinopathy?
There is a copper wiring sign, there is silver wiring
It's
sign,
like
Salus sign.
so first copper wiring comes or silver wiring comes?
Copper wiring comes first.
Okay. And what is Salus
There
sign?
is Salus sign is there is a deflection of the when there is a AV crossing is there.
And what is bonnet sign?
Bonnet sign is a
And what is gun sign?
Bonnet sign is the
gun
tapering
sign
of the
is
vein under
indentation.
the.
There is a dilatation on the both sides in the vein in the gun sign, and in the bonnet
Okay,
sign
I
there is
have to
a
be
splashing.
this honest that I don't remember exactly what are the so if you are but you should know the names, okay?
Yes.
And the best thing is to say AV crossing changes are there,
Mm.
okay? Because relevance of these changes in today's world is yeah, but these are very yeah, important questions, especially in medical colleges. In DNB Institute, maybe little less. Okay, but in medical colleges, and if you have someone who is not a retina person is taking your retina case, then they may be very much yeah. Because what is happening is when we are seeing with 20D, those changes are not so very clear as they were you with a direct ophthalmoscope because of very high magnification and the field of view
Mm.
was so less, so you were only seeing those and you were tracing all the blood vessels.
Yes, sir.
Okay, so they were nowadays direct ophthalmoscope retina surgeons. I don't think anyone uses. So their relevance has come down, but for exam point of view, it is very important. Okay, so how you like to manage? And you said a probable diagnosis. So how will you confirm your diagnosis?
I would like to confirm my diagnosis on the uh, B scan and in the OC, optical coherence tomography.
Okay, so what do you see on a B scan?
Um, B scan, there is a retinal detachment, and if there is a associated any
How will you
choroidal
know there is a
abnormality.
retinal detachment on B scan? What you will see?
Uh, there is a undulating movement of the retina is noticed on the B scan.
Okay, so if there it's not a mobile retina, then
Mm. It probably the
then
old RD
how
will
will we
not have.
confirm? There was no movement only.
High intensity echogenic
So there
spike
is
will be
inco.
seen.
So first of all, you have to describe how is the appearance.
Okay.
Okay. So how will be the shadow like? Will you see dots?
Dots are not seen in the
Not seen. Na? So what is seen? That is what I'm asking.
Membranous ecos.
membranous echoes.
So
Yes.
you have to use this word. And this word is not only important for your exam. If you're reporting
Mm.
USG or if you're doing a
Mm.
USG, that is what you are seeing a membrane.
Yes.
So if you are seeing a membrane, then what can it be? I am saying this is not a retinal detachment. You are saying a membrane tha, it is a retinal detachment. So what else can it be?
PVD.
Posterior vitreous detachment.
Yes. So how will you
Mm.
differentiate a posterior vitreous detachment from a retinal
After
detachment?
movements. After
Increase
movements will
Echogenic movement, there is a scan waves are there in the below the B scan. There is a difference in the retinal detachment and the PVD.
What is the difference?
Uh, on movement, there is a retinal detachment, low continuous spikes are seen, but if in PVD there are no continuous spikes. Sorry,
So you will see membranous echoes. There can be
Even when
either,
the
yes,
gain is reduced.
pardon me?
Membranous echoes are still present in RD even when the
IRD.
gain is increased.
Okay. So what does that suggest?
It suggests that it is retinal detachment and not PVD.
Okay. So you said there can be PVD if it is a membrane, or there can be RD. Can there be anything else?
Choroidal detachment.
Yes. Okay.
Choroidal.
So three things you have to differentiate whenever you see a membrane. Whether it is a posterior vitreous detachment, okay, you start from inside, okay. Whether it's a posterior vitreous detachment, whether it's a retinal detachment, whether it's a choroidal detachment. Okay. How do you
Yes.
differentiate? Is first is the mobility.
Mobility. Yes.
Okay. Will retinal detachment is mobile or immobile?
Mobile.
Then how will you
Depends
differentiate?
on the old or new
Then
it
how
is
will you
used.
differentiate a new RD?
Sir, gain is increased and
No,
on that.
movement I am talking about. Yes, somebody was talking, please. Dr. Mrinmay?
Sorry, sir. What was the question?
Yeah. So how will you differentiate RD with PVD on the basis of movement?
Uh, we can make the patient supine and then we can make the take the scan in standing position and then we can
What
see
is
if
that?
the
What is that
shift,
called?
shifting fluid sign.
And what is it's present in which cases?
So it is present in exudative RD
Mm.
and it is totally absent in TRD because the membrane is very taut and it is not present in RRD. It can be, but not very evident as ED.
No, no. So this is not what we are looking for. What we are looking for is, so posterior vitreous detachment and retinal detachment both will be mobile. Okay. But so how you check for mobility, Dr.
after
Deepti?
movements.
Yes, exactly. So what is after movement?
So as the patient keep the probe positioned and ask the patient to move their eye, and if
Mhm.
the you see after the patient has moved their eye, you still see the membrane floating, so more suggestive of a posterior vitreous detachment. And if the membrane is not floating after the movement, it's suggestive of retinal detachment.
Yes. So what you have to say, you have to check for after movement. So what is after movements is, see, if you ask the patient to look up and down, right and left, there will be movement of a retinal detachment also and a posterior vitreous detachment. But once the patient has stopped moving his eyes, he's just looking in front and your probe is there. But still this membrane will be moving
Moving.
slowly, slowly, slowly. So this is after movement. That means the movement is after stopping the eye movement.
Mm.
So if the membrane is still moving after the patient has stopped eye movement, that is more suggestive of a rhegmatogenous retinal detachment. So that is one point. Second point is amplitude. So it will be high echogenicity. Okay. So the amplitude will be more, but again, it is suggestive. Can the amplitude be more even in a posterior vitreous detachment?
Can be, but
Yes.
So what are the reasons?
Long-standing cases.
No.
Some
If it is
With
incomplete period,
subhyaloid hemorrhage.
No. So, yes, if it is lined, if something is attached to the vitreous,
incomplete.
so if there is blood, if it is a bloodline, so that blood, because of RBCs, the echogenicity will be high. But what will happen? It will be a variable echogenicity. Okay, superior it will be little less. Where you're going down, it will be little more.
Hmm.
Okay, so you will see the variable spikes.
Hmm.
Okay, in that same membrane, the spike is changing. But in a case of retinal detachment, even if your spike is on macula or it's on aura, it is the same content because retina is having the same content, so it will not be variable. Okay, so high echogenicity and no after movement. Okay, these are very important points. Okay, and choroidal detachment will be like a dome shaped elevation
Dome shaped television.
with no movement. Okay,
Yes, sir.
okay. So you always have to say that on B scan, I will see a membranous echo with no after movement. Okay, so it can be with good mobility with no after movement, or it can be no mobility and no after movement. So if it is a long standing RD, so why in a long standing RD there is no movement? What happens, Dr. Dipti, in a case of long standing RD?
Proliferative vitreous retinopathy.
Atrophic changes of the
Yes,
retina.
not atrophic changes, there will be proliferative changes.
Proliferate.
Okay, atrophic is a very wrong word to use. In fact, there is proliferation.
Proliferative changes.
So there is proliferation of cells, okay, and these lead to, okay, so this is not fibrovascular proliferation because there is no vascular component now. Okay, don't use fibrovascular proliferation. This is proliferative vitreoretinopathy. Fibrovascular proliferation means there is fibrous and vascular. So this is a rhegmatogenous RD. There is no problem in the vascular content here. So there is no fibrovascular changes. There is only proliferative vitreoretinopathy, which will lead to stiffening of the retina. Okay. Okay. Yes. So you will like to confirm your diagnosis by doing a B scan. Okay. And as you said, a OCT. What will you see on OCT?
The vitreoretinal interface is the same.
Vitreoretinal interface. What do you want to do? You will diagnose RD on vitreoretinal interface.
No, no,
What do you see on vitreoretinal interface?
any traction is there
Okay. Which area are you
for
scanning? The macula, right?
macula? Yes, sir.
So there can
Fovea.
be vitreomacular traction.
Yes.
Okay. But that will not lead to a rhegmatogenous RD, right?
Separation of NSR
Sir.
Yes.
from
What
RP.
NSR?
From RP,
What is NSR?
neurosensory retina.
So don't go for short forms. Okay. Go neurosensory retina from RP. Okay. What is the other name for this, Dr. Dipti? You'll see your consultant saying, oh, I can see that. There is a lot of that. So what is filling the space? It is separated.
Subretinal fluid.
Yes.
Subretinal fluid.
Yes. So you will see subretinal fluid. Okay. And how will be the appearance? So if you are seeing subretinal fluid and separation of neurosensory retina from RP, in what all conditions you can see that?
In
CSCR.
CSASME,
Yes.
CSA,
CSR, very
macular
good.
edema, diabetic macular edema.
Yeah, sometimes, but not so to so much extent. And CSR का भाई?
PNVM.
Not CSR.
Exudative RD.
Yes, exudative RD.
Exudative.
So now how will you differentiate an exudative RD from rhegmatogenous RD by doing an OCT? You said you want to confirm your diagnosis by doing an OCT, right? So basically, I am asking you what is the difference between a rhegmatogenous RD and an exudative RD?
There will be a mass.
Sir, an exudative RD,
Mass will
depending
be
on the
seen in the,
inflammation, there might be even some vitritis or vitreous cells we can see.
Okay.
but that is
Then
not on the OCT, no?
So OCT also, as you said, the vitreoretinal interface between the vitreous and the retina,
And
you can see some white dots, hyperreflective dots, which can be suggestive of cells, but they can be even seen in case of PVD sometimes. Okay. So, and next, what are the difference? There will be inflammation. Okay. Other thing?
so the
there may
turbidity
be
of the
the
fluid.
mass, maybe a hyperreflective
No.
lesion may be there if
What is the difference in the appearance of the retina?
thickness may be the
Elevated
it,
bullet type presentation will be there in
They can be there
exudative
in,
RT.
you can have bullous retinal detachment, even in
Corru
regular case.
corrugations will be there.
Yes, in which case corrugations will be there.
Re Rhegmatogenous
in
retinal.
rhegmatogenous will be
So
there,
when you see
corrugations will be
a
there.
rhegmatogenous retinal detachment on OCT, you will see the corrugations and the retinal folds. Okay, it will not be like a smooth elevation. Okay, so these are suggestive of a rhegmatogenous RT because the exudative RT will be smooth. Okay. ठीक है. So you have confirmed on OCT, you have confirmed on. Okay. Then what will you do?
Then we have to depends in this patient break is in the superior part and involving the retinal detachment involving the macula, so we have to do hello
Yeah.
um vitrectomy is done and then
Not is done. The patient is sitting in front of
sorry,
you. What do you want to do?
first till the surgery we have to give the position of the position opposite to
Locate the break first.
Break has been located.
opposite side on the same side of the break we have to give the position till the surgery,
Okay.
so
Locate the break.
fluid
See
should
the
not
break.
extend the break
Okay.
to
See the
prevent the
break.
extension.
Now if the
Extension.
patient says ki I don't want to do the surgery. Okay. He says simple, I don't want to do the surgery. What are you going to tell him? Is there any treatment, non-surgical treatment for retinal detachment, which is mentioned
Rheumatic
in past?
retinopathy.
No, he says no touching my eyes.
Sir, if right lateral position is given, there is a no treatment, but right lateral position will be given, then would not be extension of the RDN RP function
Yes. So
will improve.
in olden times, what was the treatment? Yes,
Um,
absolutely brilliant, Dr. Pratmesh. Okay. It was bilateral patching.
patching. Okay.
Okay. So if your patient is saying, I don't want to do any surgery, if your patient is in ICU, okay, he's saying, अरे मेरे को इधर चलने को नहीं हो रहा ये वो I don't know, I'm going to survive for 10 days. You are saying do this surgery. There is no guarantee. What you do is bilateral patching
Patching.
because what we said is what type of traction is this?
It is a
Like
dynamic traction.
metagenous, which type of traction?
Dynamic.
Dynamic traction.
Dynamic traction. So that means it changes with movement.
Yes.
Okay. So you don't want any movement to happen. So how you do is if you close one eye, then the other eye moves, this eye also moves. These are conjugate eye movements, right? So you patch both the eyes so that there is limitation of eye movements. Okay? Okay? And this is not just for your viva purpose, but even in cases where you find that surgery cannot be done for some reason. Okay? Like a patient is in ICU or he's under trauma or something. So you just do bilateral patching. Okay? Not for someone who's walking, talking and he says, अरे कुछ नहीं मेरे को ड्रॉप दे दो मेरे को नहीं करना है. Okay, still you should advise them rest. Okay, till the time of surgery. So what are the options? Three options. So where does your patient stay? Where does he live?
It's in the same city, sir. In same city.
Okay. So what are the options? Three options. Give me fast.
One is the bilateral patching, other is the surgery.
Bilateral patching is over now. Surgery, three options. Give me.
Surgical options.
Yeah. Is there any other option now left?
No, there is a
There is anyways no option. So tell me three
yes.
options fast.
Uh, Scleral buccal,
Yes.
pneumatic retinopexy, and vitrectomy
Yes.
with
So
the
I
drainage of
will give the
SRF.
three options. Now this patient is saying कि surgery के बाद I am going to meet Dr. Soni in Mumbai and I am going to fly by flight. Okay.
So rheumatic will not be the choice for this
Why?
patient because gas will expand and by flight it will causes expansion of gas causes the raise in the intraocular pressure.
Yes. Okay. Okay. How old is your this?
82 years old.
Okay. So is she ready to sit down with her maintain
No,
posture,
that's yes, and that is one of the reason to for
not go for?
non-compliance, not go for the pneumatic retinopexy
Yes. So what do you do
or
in pneumatic retinopexy?
um, air bubble is sorry perfluorocarbon is injected in a
Which perfluorocarbon liquid?
no
Anyone? What do we do in pneumatic retinopexy? So basically, what we are doing is we are going to insert gas. Okay, these gases are expansile gases.